when you are falling in love, it is abducens nerve that helps you to steal that first side glancy. Hi, it is Dr. Kenny and this is NeuroSketch. Welcome back to the series of discussion of extraocular muscle, and today we are going to see what happens when the love nerve is gone, and that is abducens nerve. So the abducens nerve Palsy, it is the only job that I have with you today. So let's begin. Abducens nerve palsy is the topic of discussion today. Abducens nerve palsy, which is cranial nerve number 6. So what is abducens nerve, lady? Abducens nerve is the cranial nerve number 6, cranial nerve number 6. And what does it do? Remember this formula. The cranial nerve number 6 will innervate the lateral rectus muscle. The lateral rectus muscle is the muscle that will be innervated by the cranial nerve number 6, lateral rectus muscle. So what is the function of the abducens nerve? So from the name abducens, abduction, abducens, abduction. So listen to the word abducens. So abduction is the only function of the abducen nerve. So the abducen nerve has got only one function, and that is abduction of the eye. Just like me, I've got one and only one function, and that is to one and only one job, and that's to make your life easy. So me and abducens nerve will have a lot of things in common, correct? So that's the function of the abducens nerve. So if we go back to see all these muscles, the extraocular muscle, you see this is the lateral rectus muscle, which is cut, so as we could see the inside. But the lateral rectus muscle will be innervated by this nerve, and this nerve is what is known as abducens nerve, which is cranial nerve number 6. The cranial nerve number 6 has got only one job, and that is innervation of the lateral rectus, and the lateral rectus has got only one job, and that is abduction of the eye. It is abduction of the eye. So what is the function of the lateral rectus? What is the action of the lateral rectus? That will always be abduction. So abduction is the only function of the lateral rectus. So what if we remove this abduction? So what if we have damage to the abducens nerve, cranial nerve number 6, the nerve that will supply the lateral rectus? The lateral rectus has the function of abduction. So we are removing that abduction function of the lateral rectus. So what will happen? The eye will little bit adduct. So cancellation of the movement of the lateral rectus will result into adduction. So what is this a concern? Why is this a concern? Why is it a concern? So it is a concern because the patient will have double vision. Why? Because one eye is pointing, one eye has the correct arrangement, but the other one is a little bit like, okay, this one has got a trouble, so it will move a little bit to the medial side. So these two muscles, two eyes will have misalignment, meaning that one is pointing this direction, the other one is pointing in at a different direction. And you remember that both eyes should be aligned at the same toward the same object, toward the same optical axis. Okay, so when you have misalignment, it will result into double vision. Why double vision? Because the brain is getting two images, different images from the same from the eyes. So these eyes bring for example, he's bringing the image of this one, and then the other eye is against a little bit, it is grazing a little bit on side, so it brings another image. So the brain is getting two images, and that is what you say the diplopia. It is discussed somewhere, of course. So what do you think? What kind of diplopia will it be? Will it be horizontal diplopia or vertical diplopia. So it will be the horizontal diplopia. Why? Because the eyes have horizontally abduct. So abduction is a horizontal movement. So either towards or away from the midline, but it is a horizontal movement. So the patient will have horizontal diplopia. He gets double vision when he looks, and that double vision, for example, you see two things. Well, why you actually have only one thing. And how do you bring about this diplopia? You can try to you can simulate yourself to get this the horizontal diplopia. So if you press on the sideways, and then you see like you get double vision from object, and then that double vision would be the horizontal diplopia. So that's the main symptom that the patient will tell you that I get double vision. And what kind of double vision? That will be horizontal double vision. So you as a clinician, what will you see on this patient? So number one, the patient can come to you with intentional closure of one eye. And remember, the intentional closure of one eye, it intends to correct, like to avoid diplopia, to avoid double vision, because I get double vision. If I close the affected eye, then I get only one vision. So that's perfect to me. I mean, it's not perfect, but it corrects, because diplopia is so much disturbing. So double vision is so much disturbing. So, and they are trying their best to avoid this double vision. Okay, double vision. But what else will you see? So you can see the eye misalignment, and you see the eyes are located and are pointing into different directions. And this eye misalignment is what we call strabismus. So strabismus is another word for eye misalignment. Eye misalignment is also known as strabismus. Strabismus is eye misalignment, meaning one eye is pointing to this direction, the other one is pointing into a different direction. Okay, so they are misaligned. So the affected eye is what we describe. So we describe the affected eye. So this one has got no problem. This one that has deviated is what we say it has got strabismus. So strabismus can be, for this horizontal movement, strabismus can be internal strabismus, meaning it is pointing towards the midline, internal or medial strabismus, or the common word is internal strabismus, or we can have external strabismus. External strabismus. So what do you think in terms of abducens nerve passes, in terms of paralysis of the abducens nerve or paralysis of the lateral rectus? So the patient will have medial deviation. Why? Because we have removed the lateral rectus, and the lateral rectus was the one that was abducting the eye. So the patient you see the medial deviation of the eye, or the so-called the internal strabismus. Same applies, and it is just the same name. So in your exams, some questions you're solving, you will find that the patient had internal strabismus, or the patient had medial deviation of the eye. Medial deviation is also known as the medial strabismus. Okay, the medial strabismus, and this medial strabismus is seen just as primary gaze. So for example, this one, you see this one, this is the axis, and you see this one is normally aligned, but this one has deviated the midline, has deviated the medial side. So it was the people were supposed to align to this line, but it is not on the line, so it is deviated a little bit on the medial side, and that's the medial deviation. What else will you see from this patient? It is inability, when you are doing examination, when you are telling this patient to look at sideways, the patient will fail to abduct the affected eye. The patient will fail to abduct the affected eye. Why is this the case? Because the lateral rectus is gone. The one that is associated with abduction is gone. So the patient will fail to abduct the affected eye. So I want to brainstorm you. So look at this picture. Look at this little boy here, and I want you to give you a thought and tell me what do you think is wrong with this boy? What is wrong? So think for 5 seconds. You can try to pause this video, or you can give it a thought for 5 seconds. So 1, 2, 3, 4, 5, andiamo. Let's go. So if you said for sure, we cannot tell for sure what's wrong with this boy. So we have possibilities. We cannot be specific at this point. So if you say the right eye has got trouble with the lateral rectus, you might be correct, but you might not be correct at the same time. Okay, because the truth is you really need to know where does this boy look at this point. So if he looks forward, if he is at a primary gaze, if he looks forward, I can agree. If we look forward, I can agree that the right eye has deviated medially. If it has deviated medially, it means we have no action on the lateral rectus on the right side. Correct? So maybe most of you thought that would be the case. Of course, it could be the case. I'm not sure, because we need to inquire more information from the patient. Number two is the second possibility is maybe this little boy is trying to look to the left side, because if he's trying to look to the left side, it means this eye has got no trouble, because it has moved to the left side, it has gone to the left side, so it has got no trouble. And the left eye in this case will have failed to abduct. So we have two possibilities depending on whether this patient is looking at. So if the patient is at the primary gaze, I can agree the problem is on the right eye, because it fails to stay normally, to be aligned, to look straight forward. But if this patient is looking to the left side, which is quite a possibility, if he's looking to the left side, it means the right eye has got no trouble, because it has moved to the left side, but the left eye has not moved to the left side, and so the problem could be on this side. So this is to say you really need to know where is the location of the eye, where is the gaze of the eye. So we do test we do test these eyes. First of all, you at the primary gaze or primary position, when the eyes are naturally and they are on original state or natural state, like looking forward, and it's the time that we test these eyes. Okay, so I want to emphasize one more thing, which I already emphasized the other time, that in a primary gaze, in a primary position, it is the action of all muscles that will bring the eye in the primary position. So the eye, it is where it is at the primary gaze. It is where it is at the primary gaze because of the action of all extraocular muscles. What are these extraocular muscles? We know all of them. So if we eliminate one muscle, for example, lateral rectus, if we eliminate it, all other muscles will do their part. So they will pull their eyes, the eye to the side, to their field of action. Okay, so if we're removing lateral rectus, it means we are removing the adductive effect. So all other muscles will continue to do their function, including adduction and all that. So that is primary gaze. So what if I tell this patient to look to the right side? Assume we have damage, we have oculomotor abducens nerve palsy on the right side. So what if I tell this patient to look to the right? The patient will fail to abduct the eye. That is guaranteed. We know the patient will fail to abduct. But you see the eye has moved, because it was medial to this line, but now it is aligned perfectly, as if it is in a primary gaze. What does it mean? It was like medially rotated, medially adducted, and then now it has gone this side. When I'm telling this patient to look to the right side, so the left eye has moved with no trouble, so it has moved to the right side with no trouble, so it has moved to the right side. But the right eye has moved a bit of movement. Why do you have this bit of movement? Why do you have this little movement of the little adduction and little abduction, and we know that the abducens nerve is gone? I will tell you that. Remember when I told you that superior oblique and the inferior oblique, they are weak abductors. So they will abduct just a bit of abduction. But the chief abductor, we know the chief abductor will be the abducens nerve. But the superior oblique and the inferior oblique also, they will do a little bit of abduction. And this abduction is what the abduction by superior oblique and the inferior oblique is the one that gives us this gaze. So when you tell the patient to look to the right, the eye will look a little bit lateral, so the eye will abduct a bit. Why? Because of the action of the superior oblique and the inferior oblique muscle. So what if I tell this patient, what if I tell this patient to look to the left side, to gaze to the left side? Of course, there is no trouble with the left side. So because we have no trouble with the left lateral rectus and the medial rectus and all other muscles that are functioning just correctly, with the exception of the right lateral rectus or the right abducens nerve, which can be witnessed under the primary gaze and when you tell the patient to look to the right side. So next time you see the patient with this gaze, you cannot conclude that the problem is the right lateral rectus. Why? Because if this patient is looking to the left side, the problem is on the left lateral rectus. Yeah, because he failed to abduct. So you really need to know the gaze of the patient, the gaze of the patient, the gaze of the patient. So let me tell you something here to summarize. So the lateral rectus muscle is innervated by abducens nerve, and the injury of the abducens nerve will produce the horizontal diplopia. But this diplopia, the diplopia due to abducens nerve palsy, will improve when the patient is trying to look something near, and the patient tries to look something far away from him or her. The diplopia wasn't. So the diplopia wasn't when the patient is trying to look away at a distant object. Why is it so? Remember the accommodation trial. Of course, the accommodation trial is something else, it's another discussion. But remember, in accommodation trial, if you want to look something which is close to you, for example, if you want to look something that is close to you, your eyes will move medially. You have convergence of your eyes, so the eyes will converge. So if I am converging my eyes, it means I'm using the medial rectus and all other muscles. I'm not utilizing my lateral rectus. So I will look perfect because I've got no trouble with the medial rotation, adduction. But if I'm looking at a distant object, my eyes have to do a little bit of divergence to look a little bit away from each other, and that's divergence. And the divergence you can all see, like we are abducting, so we diverge our eyes, we abduct our eyes, so we are utilizing the abducens nerve. And so the diplopia will worsens when the patient is trying to look at the distant object. But when the patient is trying to look at the object just closer to him, the diplopia will be a little bit reduced. So it improves when you want to see the object, the closer object, but it worsens when you're looking at distant object. So on examination, as we've seen, the patient will fail to abduct the affected eye. As we have seen in the previous slide, the patient will fail to abduct the affected eye. So why is it really known as the love nerve? So why is it called the love nerve? Of course, the abducens nerve is known as the love nerve, and the muscle it supplies is also known as the love muscle. So the lateral rectus is the love muscle. So when you are looking to someone you like, when you're looking to someone you crush on, for example, you crush on or you like, you always give this you often glance sideways. You give this glance sideways, a classic sneaky side eye, or a fatty sideways glance. So look at this one. So this is how you look someone you like, someone you have crush on. And of course that flatty glance, sideways glance, it is by the aid of the abducens nerve, it is by aid of the lateral rectus muscle. So next time you are trying to look to the love of your life, so you can always think you are lateral rectus, and so you can always think you abducens nerve. So that is it, the discussion on the lateral rectus muscle, on the Abducens nerve palsy. And if you're new here, don't forget to subscribe and hit the bell button and stay tuned for more and more videos to come, and see you next time.